So good afternoon, everybody. I'm Dr. Sarah Lower. I'm a consultant histopathologist at Mid-Essex and lead examiner for the FRCPath Part 2. First of all, I'd like to apologise for the difficulties we've had this afternoon of getting this started up, but at least we're on our way. The purpose of this webinar is for us to have the opportunity to go through what is in the Part 2, so that everybody's on board and understands what they will be undertaking if you're taking the exam in April, but also to give you a few hints and tips on approach, etc., and give you an opportunity to ask questions. So please put them in the Q&A. So the Part 2 is let's go through the overall layout. It's an exam that's going to take over 2 days. It consists of surgical pathology, non-gynae cytology, the macros, OSPEs, of which there's 2 of them, long cases and frozen sections. And you must pass all the components to obtain a pass, and the pass mark is 50% in all of the components. So let's go through surgical pathology, which is the one that people seem to be most interested in. It's composed of 20 cases. And it's a complete range of systems, up to 3 cases from each, and is blueprinted to the curriculum. So by all means, the curriculum is open and accessible on the Royal College website to give you some idea of the weighting of the curriculum, but to give you some idea, very much like DGH pathology in the UK, there's an awful lot of skin in there. There'll be quite a bit of GI, for example. They're going to be the ones that are going to be represented in more, because those are the ones that we see more cases of. And just like any other working day in a district general hospital, they're going to be a mixture of malignant, non-malignant and infectious cases, because we don't, thankfully, always see just cancer. The cases come in pairs, so you'll get 2 cases per 20 minutes. So you'll be expected to spend around 10 minutes in each case. And while paediatrics and neuropathology can be included, they'll be relevant to DGH setting, so possibly base of skull, or possibly a biopsy or an excision from a child, but with a diagnosis or a differential that you should have come across in a district general centre. So,
Sarah, sorry, just before you go on to the next slide, I think your screen share's just stopped working.
Okay, let me go back to that. That's not
yeah. Your slides disappeared. So
is that there?
It's back now. Yeah. Thank you.
So we're on to surgical pathology approach. Helen?
Yeah.
Okay, perfect. So the approach is, please read through the history provided. We try and provide you with a history that should give you some hints and tips before you even look at the slides. So start thinking about what we could possibly be putting on the H&E for you. If I was going to give you some hints, I would say, and some tips, I would look at both slides quite quickly. You'll probably find one, hopefully, that you sort of go, yep, I know what that is. I can see all the features that I would like to see. And the other one you might struggle with. So it's usually quite helpful to give you some idea of which one might take you a little bit longer. Because whilst we say 10 minutes per slide, obviously one of them you might struggle with, so you might want to spend more than those 10 minutes. And really, it shouldn't take you more than 1 or 2 minutes to screen each case. There should be a good example of the diagnosis or differential diagnosis that we think that slide displays. If you make an appropriate list of the micro features that you think you can see, and think of a differential list to exclude or include, depending on the features on that slide. And start writing as soon as possible. 10 minutes seems like a very long period of time, but it does go very fast, especially under those exam conditions. Let me just move on. Important things to remember with the surgical pathology. The cases have been chosen, they've required consensus. We have a meeting where we select these cases, and a group of pathologists have decided that they're a good example. Common things are common. We're not going to put bizarre, weird, unusual diagnosis in. And there should be a classical example of that diagnosis or a sensible differential. All the cases are common in District General Hospital. I'm a generalist pathologist. I'm not specialised specifically in any area of histopathology. So these are all cases that I could quite confidently say that I've seen in my general practice, certainly within the last 6 months. All the slides have been centrally checked and to make sure that everyone sees exactly the same material. So you won't be centre dependent. Everybody gets exactly the same slide. And there are no tricks. We're not trying to give you complicated cases. We're not trying to trick you. And we're selecting them for what we call a level of an ST4. So somebody that's done about 4 years of training in histopathology. If you've seen enough cases in your preparation for this exam, then you should have seen all of these diagnoses before. How to lay out your answer. And this is pretty much the same for both the surgical pathology as well as for the long cases. I would suggest you write out the history. Make sure you've taken it on board, the age, the sex, the location. Write a micro description, just as you would for any other normal histopathology report, and then write down your diagnosis or a differential with a preferred diagnosis. What extra work would you need to do to get this report authorised and sent out? And any pearls or comments. What do you know about this particular diagnosis or your preferred differential? And please write clearly, setting out the answer carefully. And really, these reports really shouldn't be more than 1 or 2 pages long in the booklets. Please write carefully. The poor handwriting makes it very, very difficult for us to be able to give you as many marks as we would love to give you. If we're unable to read something, then we simply just can't mark it. The marking scheme is centrally set and it's centrally marked. That means that then the marking scheme again requires consensus and is cross-checked to make sure that it's appropriate for that slide. It's what we call a closed marking scheme. The marking scheme is set out on the right-hand side of this slide. 2.5 being the pass mark. No, even though it's marked out of 5 for each question, there's no score higher than 4. 2 is a borderline fail. That means you've given us the wrong answer, as it were, not the actual diagnosis, but it's safe. It wouldn't harm the patient. And a 1 or 1.5 is a fail where we feel that the answer or the diagnosis that you would have given would have been unsafe for that patient. And a 3 or 3.5 is where you've given us the correct diagnosis or differential, and you've added value to it. So those are those polls and comments that you can add to demonstrate knowledge. The pass mark is 50. All papers are double marked independently at central marking, so everybody's marked by the same people. And there's a strict marking scheme which is the same for every candidate. So we try and make this as fair as possible for absolutely everybody. But please remember, there are only 70 to 80 points up for grabs, because obviously 44 times 20 is 80. That's the maximum number of points that we can give you. And our scores are usually ranging between those 30s and low 60s. So really, the added value that you give to your answers are where you're going to score those extra points to secure your pass. Diagnostic cytology is not part of the exam that I set, but it's composed of 8 cases, again paired with 20 minutes for 2 cases. And it's usually a little bit of what they seem to think is an easier case with a harder case. They're centrally set and centrally marked. They also have a centrally set marking scheme as well. And again here, there's 5 points per case. So there's 40 points altogether, but again, with the same sort of closed marking scheme. So there's no more than 4 points for each case. And the pass mark again is 50%, so that's 20. And like I say, a strict marking scheme similar to those surgical cases. On to the macro component of the exam. So you'll be given 4 cases in groups of 2. We give you photographs, and we also give you a set of questions to go with that. Like I say, 2 cases per that 20-minute slot, so about 10 minutes per a case. And in the 20 minutes, we would like you to prepare responses to specific questions that we've given you, and we welcome marking on the photos so that you can mark out, say, for example, where you would take some blocks. After you've had your 2 sets of 20 minutes, so 40 minutes in total, 10 minutes per case, you go and meet a pair of examiners for a 20 minutes discussion of those 4 cases. They're marked at the centre according to a very strict centrally set marking scheme and only on your performance in the viva. So whilst your paperwork, the questions that you might have written answers to, and the photos are taken in, you're actually marked on your viva, your vocal responses to the questions. It's designed, this component of the exam is designed to test your gross pathology and working knowledge of minimum data sets. So have you been in cut up enough or seen enough range of specimens so that we know that you have a working understanding of the minimum data sets? OSPEs. The OSPEs are divided into 2 20-minute stations. So OSPE 1 is a face-to-face with the examiners. It's usually management or clinical governance related. It could be a scenario within a histopathology department. You'll be given the scenario at the station. My suggestion would be to read through the question, and then you're marked on your viva, your vocal response to those questions. The marking scheme is also centrally set and is quite strict, so that everybody gets marked in exactly the same way. The OSPE 2 is a written paper and is usually based around, but not limited to, things like data sets, the TNM, molecular, MDTs. You will be marked on your written answers to a specific set of centrally set questions, and also marked locally with a centrally set marking scheme. Long cases. These are 4 cases, 20 minutes per a case. They're classically made up of a renal case, a liver case, soft tissue or lymphoma, but not necessarily have to be those things, but that's what we normally give as the 3rd case, and then something else. You're provided with a H&E slide and appropriate immunohistochemistry, possibly some molecular, and with the renal EM. Set your answers out as per the short surgicals, so make sure you've carefully taken on board the history that we provided. Think about the macro and do a nice description, a diagnosis. Obviously explain the additional slides that you've given, so an explanation of the immuno or the molecular or the EM that you've been provided. And then what do you know about this particular condition? These are now centrally marked at the same time as the short surgicals and the cytology, and again with a centrally set strict marking scheme. And it's only written only, there is no viva component to this, so it's very similar to the short surgicals. Frozen sections. The frozen sections have got 6 cases and they're in groups of 3 per 20 minutes. This is then followed, so after you've had your 2 sets of 20 minutes, 6 cases, 40 minutes in total, you have a 20-minute viva with 2 examiners. The examiners will mark you on your viva, your vocal responses to the questions, and it's centrally set with specific marking scheme again. The frozen sections that have been chosen are common cases seen again in a district general hospital setting. My suggestions and hints and tips is provide a short description and a bottom line diagnosis only. The cases have also been chosen, so deferring really shouldn't be something that you go to. So you should try and avoid that if at all possible. And like I say, you will be marked on your Viva performance. So whilst there is gaps on the question paper for you to write some notes, and those will be collected in from you, it's your vocal responses that will be marked. That's going over the part 2. I can now take some questions, which Helen's going to field for me if I stop sharing. Cancel. Have I stopped sharing?
Yeah, so if anyone's got any questions, you can pop them in the Q&A box for us, and we'll see what you come up with.
This is your opportunity to ask whatever you want around the exam. We would want to help you in any way we possibly can.
Okay, so I'm going to take them as they come in. So Sarah, the first question for you is, how many scenarios will be asked for in OSPI 1?
Okay, so it'll be one scenario. You'll be given a short, brief explanation of that scenario, and then there will be leading on questions that are all based on that starting scenario. So you won't be asked on multiple different scenarios. It'll be one scenario with possibly 4, 5, possibly even maybe 6 questions that will lead on, one from each other.
Okay, and our next question is about frozen sections. So in the Viva of your frozen sections, do you answer like you're talking to the surgeon?
Yes, so the examiner should be acting like their surgeon. So they might ask you surgically based questions, and your responses back to them should be as if you were giving a frozen section report to your surgical team in the theatre.
Okay. I'm just going to skip the next question whilst I just have a think about what section it might refer to. So we've got a couple of questions actually about on the day of the exam and things you're allowed to do and not allowed to do at exam centres. So are candidates able to use devices or notes in the breaks between their components? And can they take timers into the exam with them?
Okay, so on day 1, on the first day of the exam, you will not be allowed access to any electronic devices at all throughout the entirety of the day. That's because half the candidates will be doing part of the components. So for example, half the candidates will be doing cytology and half the candidates will have done the long cases and OSPI 1. Therefore, it would be unfair to give you access to your electronic devices at lunchtime or during a break, because you will swap over and then the other half of the candidates will do the other half of that exam. If you have, for example, an emergency or a reason that you need to access your mobile phone or any of your electronic devices, including iPads or electronic notes, during that time, you need to contact or get in contact with one of the invigilators who will put that through the examiners on that site to make sure that that's okay. On day 2, you will be allowed access at lunchtime because everybody sets the surgical, short surgical components at the same time in that morning. But on day 1, no access. What we are revising, and I will be having a meeting with my examiner leads, is that you can access paper copies of things. And my suggestion would be to take a textbook with you, or if you've got paper notes with you that you want to read through breaks, that's absolutely fine. But no access to electronic devices on day 1, certainly for the entirety of the day. As with the timers are absolutely fine to take in as long as they don't make any noise. Your examiners will be giving you warnings during your different sessions, which each breaking down into 20-minute slots, and they should be giving you warnings through that when you're coming up to your full time. But as long as you have a little clock on your desk that doesn't beep or make a particular noise or disturb the other candidates, that's absolutely fine to have on your desk.
Okay, thanks, Sarah. And I think you've just started to touch on one of the next questions that come up, but could you just remind everybody which sections take place on which day of the exam?
Okay,
very quickly.
Yeah. So at the moment, on day 1, we have the long cases. OSPI 1 are usually done all at the same time, and the frozens are all done at the same time in one slot. So you will either do that in the Tuesday morning or in the Tuesday afternoon. And the other half of that is the cytology component. So day one is long cases, frozen, OSPI1 and cytology. On day two, everybody on the Wednesday morning will do short surgicals. And in the Wednesday afternoon are macros and OSPI2.
This is an interesting question, and I think the answer to which might be how long is a piece of string. How many pages do you suggest that people write in an answer book for their long case answers? I mean, I've seen everything between 1 and about 14. So.
Long cases are a bit more difficult. So like I said, to short surgicals, 1 or 2 pages, it's very difficult to look at a H&E slide, think of what you're going to write it down. And once you go over 2 pages, you're going to be running out of time. In the long cases, I don't want to put a limit on it, but I think once you get into, if you think about, we're doing cases more and more day to day that are more like long cases where we do, you know, we see a H&E, we need to order some in there, we need to do some extra tests, etc., etc. And if you think of when you type that out, it's probably only a couple of pages, even with all the patients and clinical details on it. If you're going into 5 or 6 pages, you're going to run out of time. So you need to think about, how would I write this report in my day-to-day practice? And that's the sort of information you need to put in. And then the additional comments or pearls where you want to access your extra marks, again, 1 or 2 pages is probably more than enough.
Okay, so then we've got a question about marking. And I think the main answer for this is it's slightly different depending on the section. So if I ask it, I'm going to ask it about the centrally marked components because it's a bit more straightforward for that. So will the same examiner correct a specific question for all candidates?
Yeah, so we try our very, very best for all centrally set components to be marked. So the same question is marked by the same team of examiners for everybody, so that they use the same consistent marking scheme and the same consistent understanding of that marking scheme for absolutely everybody. We do our very, very best. It's not 100% possible to do it, but so far we've achieved that. And so if we've had to change or think about something slightly differently, we have applied that to every single candidate that has set that exam for that particular question.
Right, I've got a couple of questions about long cases that I've just seen in front of me. So the first one is, how are they marked? So sort of how many marks are available? Do you have any advice for maximising your scores in those? And are you generally expected to come to a definitive diagnosis in view of extra work given?
Yeah. So I'll answer the second one first because it's a bit of an easy one. In theory, and I think we do, we give you everything that you require to come to a definitive diagnosis. So everything you're provided with should be able to give you a bottom line single diagnosis. So then you can write lots of additional information about that diagnosis to get you extra marks. If you are in doubt in any way, you can offer other things that you would do. So, for example, we've given you a tumour, we've given you the immuno that should give you that diagnosis, but you know that there would be more in the panel that would be done normally in normal practice. That's just demonstrating really good knowledge and understanding of that case. But you should have, like I say, enough in front of you to be able to make the diagnosis. Just the scoring is a little bit similar to it is a closed marking scheme. The top mark is 15. I know it's marked out of 20, but the top mark is 15. 10, obviously, therefore, is a pass. So you've given a safe answer. 8 or 9, probably 9 marks, not the correct answer, but what you've given is going to be absolutely fine, wouldn't harm that patient. When you get down to the 8s, 7s, you're starting to, what you've given as a diagnosis is probably going to cause harm, and we're going to get a bit concerned about that. To go up from that 10, probably to go from 10 to the 11s and 12s, you're just going to be making sure that, for example, if it's a cancer case and it's a tumour of some sort, and you've given all the appropriate additional things that would be in a data set, a minimum data set, you're starting to score high on your 11s and 12s. To get your 13s to 15s, you probably need to add additional information. What do you know about this diagnosis? How is it treated? Is there any follow-up treatment? Say, for example, it's a melanoma. They need a sentinel node, or they might need a re-excision. So things like that, demonstrating knowledge and understanding about that particular diagnosis would then start to climb higher on that marking scheme.
Thank you. So just answering a couple, we're answering a couple in the chat box that are a lot quicker and easier for us to just say yes or no to. Okay, we've got, I'm going to leave those ones till the end. Okay, so we've got a question about the macros. Should you be very accurate with the diagnosis on the macro, or can you give differentials as part of your answers?
Yeah, so some of the macro questions you'll get asked is obviously describe this case. It's basically what would you do in the cut-up room? So how would you describe this case? Then the next question might be, well, what do you think the diagnosis is? We usually leave that relatively vague. We need sort of sensible answers that look like what you can see on the pictures. Often, not always, but not often, they're not specifically on one diagnosis only. They will allow you to give a reasonable differential, yes.
Okay, and question about the surgicals. Are these more like a spot question, or are they asking more about differential and ancillary studies?
So it's literally just like my working day. I might get a tray of cases. Some of them, yep, I know what the diagnoses are. One-liner, it's almost one-liner answers, easy, next, move on. Some of them I get coming along, oh, I don't know what that is. I'm not sure. What am I going to do? How am I going to sort it out? Do I need also immunohistochemistry? What's my differential? What am I thinking about? So we try and choose cases that are a mixture of both, ones that you should be able to pick out and spot, and there really is only a single diagnosis, and also ones where, yes, you do need to offer a differential, a sensible differential that is representative of what you can see under the slide, on the slide. And how are you going to work it out? What are you going to order? Is that immunohistochemistry? Is that possibly some special stain, etc.? To demonstrate that how you would sign that case out in the end.
Okay, so another question about the frozen sections. When you come to the Viva, do you need to do things like introduce yourself, confirming things about the patient, such as name, age, procedure, and then proceed with answering? Or can you just be straight to the point and go straight in on what you've looked at down the microscope, basically?
So the examiner should, in theory, lead you onto let's do number one. What did you think about that? Or let's do number two. The way I did it when I went to the exam, the way that I teach my own trainees is I would say at the start of the Viva, for all of these cases, I would confirm the name, date of birth, hospital number, and the location of the section with the surgeon before giving them the report, as well as understanding who I'm giving that report to. You can demonstrate that knowledge because that's how we give our frozen section reports when we give them over the phone, because obviously we can't see who we're giving them to, and we document those things. And then you've covered it. You've covered it in literally 10 seconds at the beginning of the Viva. The examiner should say, okay, thank you very much, and then move into giving your answers for each of the questions. This particular Viva does normally go quite quickly because they're relatively short reports, even though they're 6 cases.
Okay, and another question about frozen sections to keep us on theme. Should candidates give a definite diagnosis for every frozen, or will some be something like low-grade spindle cell lesion?
We're trying to pick them so that you should be able to give a definitive diagnosis or a good umbrella bracket. So when I say a good umbrella bracket is, say it's a lung, they've given you a radial resection of lung and they've asked you to do a frozen section from it. You'd be able to say to them, you know, our big umbrella terms in lung, for example, are small cell and non-small cell. Okay, so you could say this is a non-small cell carcinoma. Perfect, wonderful. They might push you a bit more on that, and could you give us more? They might say that's absolutely fine because that's all you could possibly do on it. But they're not going to give you something that's going to be massive. We're not going to give you something that's massively broad, because we want to be able to have a discussion and more definitive diagnosis.
I think that was the last one. Oh no, there is one more about frozens. So are there any situations in the frozens where a diagnosis could be deferred, or is it that they should never defer a diagnosis as part of the answer?
So the marking schemes do allow you to defer, but we think and we hope that we've given you cases that should avoid that need.
Okay. Okay, there's a question about reporting systems. So is it okay to use CAP-related reporting systems, especially the staging system?
We're an exam that's set in the UK with our own data sets. We prescribe to the TNM here in the UK. So if you think about the AGCC, that's slightly different from the TNM that we use here. Our data sets, or the Royal College data sets, and this is the Royal College exam, are freely available. They're all there on the website, easily accessible. My strongest advice is to make sure you know those really, really well for this exam, and have a very good working understanding of them. Some of them are very big, but in a sense, they're textbooks in their own right. And I would, if I was you, stick to those rather than use other systems, because the CAP is more geared towards, for example, the American board, whereas obviously this is the FRCPath.
Okay. We're going to summarise this because we've got quite a few questions on the same subject, which is about the closed marking scheme that we use, which is essentially, please explain it. I think it's more that we say we have a maximum notational 5 marks available for each case, but not all cases will ever go up to the full marks available. So what is the rationale behind that, I think?
I'm going to be utterly honest. I don't know what the rationale is. I took the exam 12 years ago, and I think it was that way 12 years ago. It is what it is, unfortunately. I do apologise on the fact that I can't explain it any better than that. But that's the way the closed marking scheme works. It starts, our maximum is 4, but you could write nothing for your answer and you would get 1 point. So it's an unusual way of doing it, I suppose, and it's difficult to understand, and I can't explain it any better. I don't know why that one's particularly used.
Okay, so we've got one about making sure you answer all your cases in the time that you're given. So if you miss the time to answer one case because you didn't feel like there was enough, do you go straight on, or do you get to return to cases?
So the slides won't come back to you. So for example, let's use the short surgicals. You've had your 2 cases, you've had the 20 minutes. The slides unfortunately do need to move on. You need to move on to the next candidate. You are welcome, say you've had case 1 and 2, they've moved on. You've now got case 3 and 4 in front of you. You've done 3 and 4, you're quite happy with your answers, and you've still got 2 to 3 minutes left. There's nothing to say that you can't go back in your paper, back to 1 and 2, and carry on doing some more work. but you will not get the slides back to have another look at. You need to use the 20 minutes that you have with those 2 slides and make sure that you've seen everything within that time. You will not be getting the back. And that's the same with the long cases. The long cases, you have long case 1, that will then be taken on and moved on to the next candidate to give them their opportunity for 20 minutes to see it. But if you finish, say for example, you then get long case 2 and you're happy with your answer for long case 2, there's nothing to say that you can't add something that you've thought of or you haven't quite completed long case 1. You can go back and do that. The only thing I would say to you though is during your rest stations, you are not allowed to add anything to your papers. The rest stations are for rest. You must close your books and take the 20 minutes to take a rest. This is a good time to have a bathroom break, take on some water, have a sweet or something, or whatever's going to give you a bit of comfort, but you can't add anything in that rest station. The reason for that is because the rest station is staggered. It is at different times for different people. And if somebody, for example, hasn't had the opportunity to start any of the written components of their exam, it would be unfair again for them to if other people are allowed to write in those rest stations. So nothing in the rest stations, but there's nothing to say that you can't use other time within the exam, the written and the active part of the exam to change on add to answers, but you will not get the slides back either.
Okay, I think this one's come up across a few things, that if you don't quite, or even if you do reach a definitive diagnosis with something, what could candidates do to try and just eke out the extra half a mark that's available? So you've got your 2.5, you got the correct diagnosis. What other things are you looking for to up the scores?
Okay. So I will use a diagnosis where we can do a really easy marking scheme and think about it. Okay. So you've been given a bladder biopsy, and the clinical information is I don't know, a 62-year-old female, red area on bladder wall, biopsied. You have a look at it and you go, oh, I know what this is. I think it's malakoplakia. Fabulous. That's your diagnosis. You're looking around, make sure there's nothing else going on. Is there any CIS in the background hiding? Have those examiners been horrible and put something that's really sneaky in there? No, you're happy it's malakoplakia. Fabulous. So your 2.5 is that malakoplakia. Okay? Your 3 or 3.5, or even getting to that 4, is what stain would you use to prove it's malakoplakia? Yeah, so you can use a pearls, you can use an iron stain to prove that it's malakoplakia. What causes malakoplakia? Well, we know malakoplakia is caused by E. coli infections, repeated E. coli infections. So you could add that as information. Okay, so you add in things that you know, like what additional tests could you do to prove it? What are those little bodies called? The Malacus gluten bodies. Pronunciation's awful, but you know that could give you another 0.5. Where you're going to go down is if you've just called it inflammation. So you put it, that would put you into the 2. It's not a dangerous diagnosis, but you've missed the core diagnosis that then would indicate to the consultants, your urologist, oh, does this person have repeated infections? Is that something that we need to treat or look at? Is there a reason why they're getting these repeated infections? If you've said that there's CIS or you've said that there's an invasive malignancy, that's obviously your 1s and 1.5s. So that's how you do it. 2.5, you're going to get the diagnosis. What do you know, or what additional tests would you do? And what do you know about that case will give you that 3s, 3.5s and above.
Okay, so on a similar note, got a question which I think is really about egregious errors. So could you give us examples of sort of vital mistakes, and at what point you would start to consider these sort of things vital or not?
So it really is this going to harm a patient? Is the diagnosis you've given going to harm a patient or change that patient's treatment significantly? So the absolute classic is what we call the benign malignant reversal. So the case is benign, the diagnosis on the H&E is benign, but you've given a malignant, or you've put in your differential of malignant diagnosis that's going to make sure that the patient gets more possibly radical surgery or chemo or radiotherapy, okay? So that's going to cause harm to our patients. Those are the things that are going to be marking you down in the 1s and 1.5s. If it, like I say, if it's a diagnosis that you've given that isn't quite what's on the H&E or what we were aiming for, but isn't going to change or harm that patient, then that's where you're going to get your twos. So, for example, it's a skin excision and it's an adnexal tumour, and you haven't said what type of adnexal tumour. You've just said it's an adnexal tumour. That might well get you the 2. It might be some adnexal tumours have, for example, specific genetic associations or familial associations, which would be helpful to the surgeons. It's not a dangerous diagnosis. It's not going to cause the patient any harm. That's absolutely fine. But if it was a benign adnexal tumour and you called it cancer, like a BCC, for example, then that might get you down to the 1 or 1.5, because that patient might end up, for example, if it's anywhere in the face, what we call the high-risk areas, they might have to have a wider excision. That's obviously going to leave the patient with quite significant scarring. So those are the sorts of things. We've got to consider whether the diagnosis is going to cause patient harm.
Thank you. So that's a good one I just spotted up here. So in the short surgicals, should you always favour a diagnosis? And are you penalised if this is wrong, even if your immuno would sort this out and correct it?
So if it's a case that we're expecting you to give a differential, and you've given us an appropriate differential for that H&E side, then that's going to easily get you your 2.5. Favouring a differential is really all about getting those 3s and 3.5s, okay? Because you can't write about, say you give 3 differentials, you can't write about all 3 differentials in your extra work and still do everything in 10 minutes. It's too much, and an immunohistochemistry panel, etc. It's just too much to try and fit in. So giving us a preferred differential might access that 3 marks. So please do it. It's a good reason to do it. It might give you that really crucial 0.5 that you need. And then even if the immunohistochemistry panel will sort it out, that might be the case of securing your 2.5s and your 3s. So it really depends on the type of case, whether it's going to make you move from like a 2.5 to a 3 or 3 to a 3.5, but it's always going to get you above that pass mark. But if you don't prefer something, it's going to be very difficult, for example, for us to understand, 1, what was you thinking about this case? Or 2, what are you going to write about? You can't write about everything. So go for a preferred. It might not be right, but normally the marking scheme doesn't punish you for not choosing the correct preferred.
So question about the long cases now. Do the long cases ever need further workup, or is it already a completely worked up case?
So not necessarily completely worked up. Like I said, we normally give you everything that you need for a definitive diagnosis. But for example, say it's a lymphoma case, there's no way that we would want to give you the entirety panel for a lymphoma case, because you'd be screaming from the hilltops that we've given you 25 slides and you've only got 20 minutes to look at all of it and write a report. So what you would have been given is the key immuno that gets you to the diagnosis. What you can do is you can demonstrate knowledge and say, oh, this is this type of lymphoma. These immunos are supportive of it, but to complete the panel, I would do X, Y, and Z, okay, to confirm that panel. And that's just demonstrating knowledge. And in fact, probably the marking scheme is asking you to do that. So whilst I say it's definitive on what we give you, and you should be able to come to a diagnosis, on most of the cases, we won't have given you absolutely everything, because otherwise it's too much material for you to look at. And that's where you can demonstrate really good knowledge and get marks.
Okay, another one about long cases here. In the renal cases, will either IF images or IHC slides be provided?
Yes, we provide both, but only as images, because obviously to cut that many to make sure that everybody sees all the same material was difficult. So everybody sees the same H&Es, And any specials like a PAS, they will all be the same for everybody. But we can't cut enough sections off a biopsy to give everybody the immunohistochemistry. So what you get given is you get given a photo with the immuno on it, and everybody gets provided with the same photo. And that's the same for EM. The EM photos are the same for absolutely everybody, and everybody gets given a copy of those.
Okay, very quick question here. I think I know the answer to this one. Are there any neuro or paediatric pathology cases included in the exam?
So as I said in my presentation, yes, they can be in there, but they will be at the level of what we call district general hospital. So sometimes I get biopsies from the nose, for example, which is called base of skull. Okay, so there should be things that should be base of skull below, if we were talking about neuro. Okay, with pediatrics, we might give you a biopsy or a H&E from a resection of a child, but the diagnosis is something you would see common in a DGH setting. So it should be something that I, for example, don't do very much pediatrics at all, but I do see skin excisions, for example, from children, and I understand what the diagnosis in children in a DGH setting might be. For example, Spitz nevus, very, very common, childhood nevus. As a DGH pathologist, I would be expected to be able to report that.
Okay, and are there any dual pathology cases in
the
exam?
Pathology on quite a bit, but that's part of everyday practice. I did two or three trays of reporting this morning. 3 of the cases had dual pathologies in them. The marking schemes are usually done so that the more dangerous diagnosis, i.e. the cancer, if there is a cancer in there, is the one that's going to hold the weight. So if you miss a benign diagnosis in the background, you probably would struggle to get better than three marks for that case, because obviously that's how you increase your marks. But yes, dual diagnoses do go in. They don't have to go in at all. It's just depending on the selection of cases, but they could be in there. But that's, like I say, just repeating what I would normally do in my everyday practice. I see dual pathology every single day and expect to pick it up.
We're getting through these slowly. So a couple of questions about frozen sections. So I feel like we've answered this already, but I think things are blending a bit now. Are you wanting a specific diagnosis for cases, or just sort of a benign malignant description? And how much description is required?
Okay, so for example, let's go back to our wedge resection of lung. Our wedge resection of lung, and the surgeons are asking about the resection margin. So if a surgeon's asking me about the resection margin, I've obviously taken it, I've looked at the frozen section. All my surgeons want to know is this benign or malignant? Is there cancer still there at the margin, or is it negative? So I would say to my surgeons, this is a bronchial margin and it's negative for cancer, malignancy. That's all they would want to know. And that's probably the marking scheme is set at that. That's absolutely fine. For a cancer diagnosis, as we said before, in that wedge, if they wanted to know what type of cancer it is, they're going to want umbrella terms of, is there cancer or not, number one. And if it was, for example, in lung, they want to know, is it small cell or non-small cell? If you've done enough of these frozen sections in your own institutes, you'll sort of have an understanding of what questions your surgeons are likely to ask you. And that should therefore help you be able to understand the amount of information that you need to get, depending on the frozen section, and the sort of questions that the examiners might ask as if they are those surgeons.
Okay, so I've got a question about the Viva components. So are there separate questions with separate marks in the Viva? So basically, if you were giving an answer and you mentioned something that wasn't in the mark scheme for that particular question, but was the answer to a later question, you were just very efficient, would you still get the marks even though you'd given the answer at a different point than the examiners would be expecting it, basically?
Yeah. So the 5 marking schemes are not set up so they're so specific, so that, for example, question 1, you must have stated this, this, and this, and if you stated somewhere else, you're not going to get the marks on that. They're stated on your overall performance, your overall explanation, and you're talking through the questions that are associated with that particular station. So say with OSPI 1, and OSPI 1, like I said, you get given a scenario at the top, one scenario for the whole 20 minutes, and you then get a set of questions that flow one to the other, that are all to do with that same scenario that you've been given at the top. You'll be marked on your overall understanding and performance through those questions, not individual marks on each. And that's the same in the macros as well.
Is there a source that you would recommend to increase your knowledge for the OSPEs?
It's tricky. Basically, if you've spent enough time in your own pathology departments and come across the everyday difficulties that it is to run a histopathology department, that will probably cover every single scenario that we can possibly give you. My suggestion is go and see your clinical leads and say to them, what issues have you had in the last 6 months that have come across your desk, and how did you deal with them? You know, what did you do with a staffing crisis? What did you do when there was a problem with a molecular test? What did you do when something went horribly wrong? What did you do if there was a colleague in difficulty, etc., etc., etc.? These are all common problems that our clinical leads come across every single day, every single week. They're very adept at being able to deal with them all the time, and they will know automatically how to deal with those particular scenarios. So my best suggestion is go and have a chat to your clinical leads, go and have a chat to whoever leads your histopathology department for a couple of hours and say, tell me all about it. Ask them what troubles you, what do you have to get involved with, and how did you, in a stepwise progression, deal with those issues, and they'll be able to give you loads and loads of information. So what do I do with my own trainees in my department? I'm a clinical lead here. Every single time there's an issue, I drag along a trainee and go, look, what would you do? How are we going to sort it out? What are we going to do next? So, you know, please go and see those guys. They're your source of knowledge for that.
Okay, right. Got a question about patient history. Is it required to write the history as part of the questions, or do you just go straight in with it?
It's really not a requirement at all to write it at the top of the thing. I only put it in there as a suggestion because I think in the panic and the stress of the exam, you forget that it's a female, or you forget that this person's really, really young, or they're really, really old. You forget where the location is. Okay, so I always, and it's a bit like when I take up a case. I've taken up a case and I look at it and I go to myself, I'm going, oh, this patient is 69 and they're female and this is on the leg. And I'm doing that before I even pick up the H&E slide. And I think it's this. And I'm trying to pay attention to all those details so that when I look at a case, I'm going, yep, it's fine. An error that I see quite a lot when marking these papers is that somebody's given a female cancer in a male patient, or they've given cancer to somebody who's a child. Okay, so they've missed some of the really key clinical information that we're trying to give you, which is the age, the sex, the location, and the clinical impression. Because we're trying to give you hints, we're not trying to trick you with those. They're all supposed to be relevant to that H&E slide. So that's the only reason why I suggest that you put it in, to make sure that you've really taken it on board and it's really right in front of you. But it is not absolutely 100% not required. It's just there to try and help you.
So got a question about immunohistochemistry that you might order as part of your answer. Do you need to include the possible interpretation of these if you suggest ordering any, and draw tables for them as part of your answer?
Yeah, if you just write me a list of immunohistochemistry, I don't know whether you can interpret it or not. I don't need to know if it's a molecular, if it's a cytoplasmic, or if it's a nuclear stain. That's fine. But please draws a nice table. So say, for example, you think it's some sort of spindle cell neoplasm and you've got a differential of 4 or 5 different spindle cell lesions. Perfect. Put them down one end, put your immuno across the top, and do me a nice table with positive and negatives. You're demonstrating loads of knowledge that way, and loads and loads and loads of understanding. And then we know that you'll be able to interpret the immuno correctly, hopefully, if you put the right positives and negatives in the right places, and therefore we'll be able to get to the correct diagnosis. And they will almost certainly earn you some extra points and marks, the extra 0.5 that you're looking for. So please do put that in there. Please don't give us a list. It's not helpful. Tables are a really good idea.
Okay, there's a couple of questions I'm going to combine together because I think you should be able to answer them in a similar kind of fashion about the marking scheme again. So is there any situation where if you got the right diagnosis but were given a 2 instead of a 2.5 as your mark, would that ever happen? But equally, if you give a list of differentials that contains the right answer, but you preferred a different diagnosis, which is the wrong one, is there a chance you could get a 2.5 on that?
I can't answer that, and that's because every single marking scheme is written definitively for the H&E to which it's associated with, and it entirely depends on what that H&E shows and exactly what has been written. So that's a very, very hard question to answer. I'm sorry.
Right. We've answered that one several times. Can candidates use abbreviations in their answers?
You can. I wouldn't. Abbreviations should really only be used if it's really clear what that is. Okay, so if you were looking at a breast case and you wanted to use the abbreviation DCIS, I think DCIS on the whole is easily understood. But you use an abbreviation that isn't used absolutely common day, it's not going to be easily understood. It's going to be very hard to mark. It could be interpreted in multiple different ways. My suggestion is if you're going to use the same term repeatedly, so for example, I can't think of an example, but if you could put down the whole word and then brackets, put the abbreviation, and then use the abbreviation going forward. That's lovely and clear to the examiner. What do you mean? And how to interpret that abbreviation. So make sure there's no misunderstanding.
Okay. There's a few questions about cytology, which if you can't answer at the minute because it's not the area that you set, I will get some answers for the candidates and circulate them around by email. So are there any borderline cases in cytology?
My best thing about the cytology is I'm going to hand that over to Helen. It's the only bit that I don't set. Dr. Hader does it for us. I don't want to mislead you in any way whatsoever. I haven't ever got involved in it. I don't actually even report cytology. So I don't want to mislead you or give you any incorrect information. So let's pass that back to Helen. She can get in.
I will gather all of the cytology cases together and get some, cases, not cases, I'm doing nothing with those, the questions. And I will get some answers for those. Okay, so this one's a bit of a long question, so I've been saving it, which is about the reasoning about needing to know expert level knowledge for long cases. So, for example, a DGH approach is to be able to recognise a lymphoma, but the exam passes to be able to diagnose what it's noted on the Leeds website as an expert level case. So it's more so in the past it was about recognising a more general approach to be able to pass, but now as we've added a relatively huge number of differentials, is it people are expected to get it exactly correct? Or I think it's more, is there a bit of leeway in your answers, or are you just looking for?
Okay, so let's go to long cases. Okay, so let's take a lymphoma because I think that's the example that they've been given. Okay, so what you have on the LEAPS website and what they've discussed on the LEAPS website, I think are exams before a certain stage, and I think it's up to about 21 is the exams. That does lead me to reminds me of something. I've just had all the most recent short surgicals scanned. Will hopefully be up on the pathology portal soon with the diagnosis with them. So that will hopefully be there for you to refer to in time for the exam. So that's a big thing that's been done. The lymphoma cases that we now put in for this exam and that we would be examining you on, to get a pass mark would be to put it in the right category of type of lymphomas, which is, say, for example, is to diffuse large B cell, then we would expect you to be able to diagnose that because we've given you the appropriate immunohistochemistry called diffuse large B cell. For you to get the additional marks above would probably be along the lines of what additional immunohistochemistry panel. Like I said, we can't give you everything because otherwise you'd be drowning in slides. So what else would you need? And then if you know more about those conditions, you will get higher. So putting it in an umbrella term or in a vague box of the type of lymphoma will easily get you a 10 or 11 marks without any problems whatsoever. And I think you should have enough experience. I'm a DGH pathologist. I do refer my work out to the lymphoma guys in London. But I would be expected to work it up here to a level of being able to at least put it in a category box, as in this is a high-grade B-cell lymphoma, or this is a Hodgkin's, or this is a T-cell lymphoma. So I should be able to put those in those various categories. But I also understand what my colleagues in London are going to do. They're going to do some molecular, they're going to do some additional immunohistochemistry, they're going to possibly do some flow if that was required for that case. So I understand what they do. It is testing it at a DGH level of, can you put it in a category box, and do you know what else we would do with this? And I think that's reasonable.
Thank you. So another question about marking. Do you audit your marking? I think that's the general you, not you specifically.
I'm not sure what they mean by audit.
I'm going to just, I think that it possibly means how much are we checking ourselves as we go along? Are we gaining consensus in the marking? Are we making sure that we don't have someone who's giving everybody a 1, regardless of this sort of thing? So I think possibly if you could just talk a bit to the things that we do in the marking to make sure everyone's.
Okay, so it's quite easy and quite quick to pick out if there was an issue. So when we do central marking, we get a little group of candidate responses, we look through them and we test the marking scheme. Is the marking scheme a fit? Have we got most people passing this particular case? Question 1, most people passing? Yes, most people are passing. Are some people getting extra marks? Yes. Is there a couple of fails? Yes, there always will be on every single question. What you can also do, and one of the things I have great fun of doing, is I look at a question and after we've marked absolutely everybody, we look and see what's the average mark for that question. And it will surprise a lot of candidates because people feel that a lot of people fail this exam. But what you find is that mark from on average across all the candidates is around the 2.5. So that gives you a really good idea that the questions are, 1, both set at the right level, but 2, that actually they're probably being marked correctly. When we get a lot of cases as they're coming in, and if I sit there with these guys who are putting them all up onto the system and going through them, if something, for example, came back and it kept coming back as 1, 1, 1, 1, 1, I'd be like going, guys, why are we marking everybody once? Is there a problem here? Is there a problem with the marking scheme, or is this a bad batch, or shall we have a quick look at this and go through it? So there's a constant feedback loop as we're marking these cases to make sure it's been done. Like I said, the same people should be marking the same question for absolutely all candidates. So how they are marking it should be equal for everybody. And like I said, we get this feedback loop all the time on it. It's marked independently by 2 people. So one person, I will be sitting there with a colleague. My colleague will mark your paper question 1, and then I will mark it completely independently, looking at the marking scheme, and then we come together. And you'll be very surprised at how much consensus I get with my colleague next door to me. We get a very good idea of where the 2.5 is, where the 3s, 3.5s, etc., where that 1 is. And that gives us good consensus quite quickly. And it becomes quite obvious if there's a problem with that, and therefore we know that the marking scheme isn't working, and then we would restart the whole process again to make sure it's completely fair for everybody. And we do that process for all the centrally marked components to make sure that it's literally as equal and as fair as possible, and to pick up any issues, either with the marking schemes or with marking, to quite quickly, and therefore making sure it's completely fair for everybody. Do we think that answers it?
Okay. So these are all cytology. Okay, few more questions again about definitive and differential diagnoses for cases. So when there's a definite diagnosis for a case, do we still have to write the differentials and explain how you would differentiate?
If you think there's a definitive diagnosis for something, please just write the diagnosis. For example, one of the cases in the last short surgicals, it was giardia. It was a completely normal duodenal biopsy, but there was giardia in it. There is no differential here. Shouldn't be any difficulties in thinking, oh, this could be something completely different. It's just giardia. The bottom line diagnosis is a normal duodenal biopsy with infection with giardia. Nice and easy. Differentials really should only be there for, say, the spindle cell lesion from the GI tract. Is it GIST? Is it a leiomyoma? Is it a schwannoma? Those you can't do on a H&E. That's entirely reliable. There's no way anybody could do it. You could prefer one. That's absolutely fine. You have to look at the morphology and see if you can pick out one. And then you would then offer what is the differential immunohistochemistry table, and then talk about your preferred diagnosis.
A couple of quick questions on exam content. Will there be any forensic cases?
No.
Excellent. I like quick ones like that. What about hematopathology, like bone marrow biopsies?
Bone marrow biopsies could go in. So for anybody who sat the exam last time, and it'll hopefully be loaded up into the Path portal, we did put a bone marrow trophine in. We had metastatic melanoma in it. So they're entirely fair and up for grabs. Histopath can also be in the short surgicals if it's a straightforward diagnosis. In this case, for example, there's a monotonous lymphoid small proliferation. It looks like a low-grade lymphoma of some sort. You would say that it's there, and you would offer a differential and how you would sort it out. So those things can be added in. The Histopath can also be done, as like we've already discussed, as a long case as well, with an appropriate immunohistochemistry panel.
Got an OSPI2 question. Could you give an example of an OSPI2 case that we've had?
Okay, so let me think of a good OSPI2 case. So let me think. You could be asked, for example, oh, you've had a GI biopsy, it's been diagnosed as an adenocarcinoma, esophageal biopsy diagnosed an adenocarcinoma. You might then get told, oh, that they've had a history of breast cancer, how would you tell the difference between the two? You might get asked of what type of molecular can you do on an adenocarcinoma from the esophagus. You might get asked what surgical procedure could be done, what staging can be done. These are all MDT related questions. They're also related to patient pathways and what additional tests we might do. So we could test, do you understand data sets? Do you understand what the MDT does and discusses? Do you understand the molecular with this case? So what we will do is we'll give you a scenario, and then the questions will lead down through that based on that single scenario, that flow from one to the other about basically a patient's journey is a good example, but it's not limited to something like that. That's just as an example.
Okay. There's a last couple of quick questions that I don't think you've answered yet, so I'm going to call these the last ones. Just because I'm aware that we've all got other things to go on to. So non-neoplastic liver and kidney cases, do they all have to be referred to their respective MDT?
Neoplasia, so the multidisciplinary team meetings, or otherwise known as tumour boards in the US, are for tumours, are for cancers or suspected cancers. However, there are multidisciplinary team meetings normally about, for example, medical liver or medical renal. So you would discuss those, but not in the traditional MDT sense of something being cancer. Please don't refer something to the MDT if it's not a cancer. Our MDTs are full, they're overburdened, they're too busy as it is, and they should really be defined just for people that have got malignancy and need that oncology input, need that surgical input. But for medical renal and liver, they do have their own MDTs that they do, but that's to discuss ongoing clinical treatment.
The last but one that I'm going to deal with. How many, just a rough guesstimate, I don't think you need to be specific because it will change from one session to the next. Would there be, and how many, cases of bone lesions and soft tissue?
As Helen says, it can be very, very, very variable. There will be something in the exam that will be testing that component of the curriculum. But we'll only ask you to answer it at the level of a GGH pathologist unless we've given you lots of additional information. But there'll be at least a case somewhere within the exam, but there's no limit on the number of cases. But obviously we can't do the entirety of, say, the 20 surgicals on soft tissue because we're trying to blueprint it, as we say, towards the curriculum, the weighting of the curriculum.
Okay, and then there's a couple of last questions about the pathology portal, which, for point of clarification for everybody, is not the Leeds website. They're going on the college pathology portal, aren't they?
Yeah.
Yeah, so this is available through the college website. You'll need to sign up to register. It's a very quick and easy process. But once you've done that, you'll be able to access any cases that we've uploaded there.
Yeah, we've uploaded, they're in the process of being uploaded. I've sent them for central scanning. There should be hopefully 2 years worth of exams going up. There'll only be the short surgicals, those 20 cases for those sittings. And they should have a diagnosis of them. I haven't had confirmation they've gone up yet, but I've been told that they'll be going up in the next few weeks. So should be in time for this sitting of the exam. The Path Portal is a beautiful, amazing place to access. It's got mountains of information and lots of academic and educational resources. So please log on, please use it. But like as Helen says, you access it through the Royal College website. If you go up to the right-hand side where you can scroll down, it says datasets, etc. It's on the bottom of that scroll down, and please click it and sign up.
Yeah. So, as far as I'm aware, anybody can sign up to use the pathology portal. There's a form. There might be 2 different sorts of forms depending on whether you're a member of the college or not. But anybody anywhere in the world can sign up and use it and access the cases that have been made available by our members for the sharing. I think that has covered pretty much everything. As I said, there's a few cytology questions which we'll leave. I will get some answers to those, get those answers circulated. Is there anything else from you, Sarah, before we?
No, I wish everybody the very best of luck. As I said, please don't think the exam is here to try and trick or confuse you or trip you up in any way whatsoever. My trainers used to say to me, push class, which means if you've seen plenty of material, you've seen plenty of cases, then you should have seen everything that we're putting into this exam. And if you haven't had an opportunity to do a renal placement or medical liver replacement, please try and get those sorted out so that you've seen some of those for the long cases. But everything else should be, pretty straightforward. We are not trying to trick or make it particularly hard for you guys. Everything is straightforward, promise.
Great. So thank you, Sarah, for presenting this afternoon for us and answering everybody's questions. Thank you, everybody, for attending and joining us. We'll be making a recording of this session available on the website in due course once it's just been tidied up. And we will circulate the link when that's gone live to everybody. So if you know someone who wasn't able to attend today, they'll be able to go on the website and see it. It will also be available for any candidates for future sessions to have a look at. I think that's everything now then. So thank you very much, everybody, and best of luck to everyone with your exam this session.
Yeah, thank you very much, guys.